All right. Good evening, everyone, and welcome to tonight's Cervical Spine Research Society webinar on cervical spine deformity. I'm your host, Byron Stevens from Vanderbilt University in Nashville, Tennessee. I'd like to thank all of you for joining us. We're incredibly excited to bring together three outstanding leaders in cervical spine surgery to discuss key issues facing surgeons tackling this challenging problem. We're going to hear about everything from preoperative optimization to surgical planning to avoiding iatrogenic cervical deformity. Before we get started, we are going to share a few updates and reminders from our CSRS leadership. First up, we have a call for grants and a call for letters of intent for our grant process from January 28th through February 26th. More information is available on the CSRS website. Also, a reminder: applications are set to open this weekend for the 2026 CSRS Hands-on Surgical Techniques course. This is for senior level orthopedic and neurosurgical residents and fellows. And really, we've sent several fellows to this over the last several years, and it has been an amazing experience with incredible opportunities for hands-on learning with cervical spine leadership from all over the country and across our society. And then a reminder, our annual meeting and instructional course will be this December 2nd through 5th in Austin, Texas, with a call for abstracts opening March 4th through April 15th. So get your abstracts ready to submit. And then a reminder for those of you who are not yet CSRS memberships, are not yet CSRS members, membership applications are open. You can use this QR code as a link to the application process. Then finally, remember to connect with CSRS on your social media platforms and join us in the conversation as we continue to pursue topics relevant to cervical spine surgeons across the globe. In particular, we've had a recent push with our YouTube channel with tons of great content coming out every single day. If you haven't checked this out yet, I would encourage you to do so. It's very well organized and very concise videos from thought leaders in cervical spine. So check that out if you haven't yet. Our agenda tonight includes talks, as I said, from three world-renowned cervical spine surgeons who have graciously volunteered their time and expertise: Dr. Peter Passias from Duke, Dr. Hanjo Kim from HSS, and Dr. John Rhee from Emory. Throughout tonight's presentations, please use our Zoom Q&A function to submit questions for our presenters. And let's go ahead and get started. Our first speaker is Dr. Peter Passias from Duke University. He is a professor of orthopedic surgery and associate chief of spine surgery at Duke. He is an internationally recognized leader for his work in adult spinal deformity, particularly in cervical and cervicothoracic alignment, outcomes research, and risk stratification. His research has significantly advanced our understanding of sagittal alignment parameters and their relationship to patient-reported outcomes in surgical planning. Tonight, he will be presenting on optimizing the adult cervical deformity patient prior to surgery. Peter, thanks so much for your time, and the floor is yours.
Thank you so much. Again, thank you very much for those kind words and warm introduction, Byron. Thank you for putting this together. I'm honored to be a member of this panel with my esteemed colleagues, and most importantly, thank you to the CSRS for the support of cervical research and cervical deformity and our wonderful society. Okay, so by way of background, we know that the etiology of cervical deformity, as you're going to hear tonight, is quite diverse. And, most recently, we are seeing increasing cases, as you'll hear, that are iatrogenic or as a result of our treatment of adult thoracolumbar spinal deformities. We know that this has a significant impact on the quality of life. And generally, surgical correction improves alignment and patient outcomes, but historically, it's been a rocky road. There's high complication rates and there's high reoperation rates. So the issue behind my talk is really the gap that remains in preventing complications and the role of preoperative and perioperative treatment in cervical deformity corrective surgery. Part of the problem is really recognizing the nature of this unique patient population that we're treating. We know that the impact on overall health state is dramatic. This patient population on average is 34% below the bottom 25th percentile for a similar age and gender weighted normative population, which is really, really dramatic in terms of its impact. We know that this patient population is more severely comorbid, more advanced in age, and more severely frail than most typical spine surgeons. And it's common for us to perform really challenging cases, and as a result, our outcomes are not always optimal. Case in point, this is a typical cervical deformity biplanar patient that we see that also has global deformity. And this patient has osteoporosis, sarcopenia, multiple medical comorbidities, but also has myelopathy and progressive loss of ambulation. So this patient, without optimization protocols and current techniques, really has historically suffered a really rocky road until finally reaching an optimal outcome with multiple reoperations. And this is exactly what we're trying to avoid. The first step in our intervention to optimize patient was the adaptation of ERAS protocols, which is a generic term that describes kind of many things, which we'll get into. Initially, this is really thought to be really only effective in minimally invasive and degenerative surgeries. However, we know in our adult spinal deformity literature, this is shown to have an impact in terms of minimizing opiates, length of stay, and readmission rates. We looked at our early application of these techniques in our cervical deformity population, and it's not like turning on a switch. These protocols require development. So we divided our patients into early, intermediate, and later groups. And we found that there was an incremental benefit as our ERAS protocols got more sophisticated for many respects in terms of decreasing ICU length, discharge to home optimization, lowering perioperative AEs, and most importantly, really better candidate selection. Jason Savage and his group looked at the literature on this. They found 10 articles of substance. And in addition to the findings that we mentioned, they also found at 2 years there was a better quality of life achieved. So what are the basic components of this catch-all term of ERAS? Well, it's not just a point in care. There's preoperative components, perioperative components, and post-discharge components. Prehabilitation is what we implemented first at our institution. It's in line with many physical therapy protocols, and the general components including a warm-up cardiovascular component, resistance exercises, and functional training with focus on the muscle groups that you can see here. A lot of our protocols at our institution are based on the lumbar literature from the Prepare RCT, which showed that about a third of variation in post-operative activity levels can be attributable to prehab. And in addition to the physical components, you can see there's 5 cognitive sessions, which really enhance that protocol. We looked at our early experience with simply based on prehab, and we found that patients met MCID at an earlier rate. Nutrition optimization is really part of any protocol. We know that this is established in many surgical fields, and we know that the parameters such as prealbumin, transferrin, and albumin are well established. There's other more advanced preoperative prediction models, such as the one seen here, which really identifies diminished physiologic reserve. And a shout out to the CSRS. This was a micro grant to our resident, Dr. Saleh at the time, who's now an attending. And we did a small RCT of patients who received protein supplementation 2 weeks prior to surgery, 2 weeks after surgery, showing a diminished rate of return to OR due to wound infections. Optimizing BMI and hemoglobin A1C, we know is certainly something we all need to achieve. However, increasingly, the question is becoming, are GLP-1 agonists the answer for both? And as you can see on the right, there's really a growing body of evidence to support this. However, we have to weigh the downsides, such as hypoglycemic events and aspiration. So I would argue that it's really early to make a call on this as of yet, but certainly it's made a dramatic impact based on the early experience. Pain optimization is really part of any preoperative optimization protocol. I think the Congress of Neurologic Surgeons really said it best with their summary statement. The use of any opioids before surgery was associated with longer postoperative opioid use, and longer duration of opioid use was associated with the following: higher complications, longer length of stay, cost, and increased utilization of resources. It's not just about preoperative minimization of the total morphine milliequivalents or even using alternatives. It's also about intraoperative multimodal techniques. And this is liposomal bupivacaine, which we've adapted at our institution for these types of cases. We found blocks to be slightly less effective than our thoracolumbar population. Tapering plan is critical. As you can see in this article, a much higher likelihood of tapering at the 1 year mark if there's a plan in place to follow up with patients post-discharge. If I had to choose one item that has made most difference, it's the optimization of osteoporosis. I can give a whole talk on this, but suffice it to say that we're really doing a better job at identifying osteoporosis patients and quantifying it, and treating them appropriately with anabolic agents more aggressively prior to these extensive realignment procedures to minimize acute failure as well as to maximize long-term healing. What is the cost of all these protocols? Well, we presented this at the annual meeting recently, and certainly there is an upfront cost in terms of prehab, bone health optimization, and nutritional optimization. However, at 2 years, the cost per quality was lower, offset by the diminished reoperation rate. And finally, I just want to touch upon, you're going to hear this probably through the night, is preoperative planning is really what we know most about in the literature of cervical deformity. And this is really part of optimizing your patient outcomes. You have to go into your surgeries with the plan. We know that the ISSG classification gave us a common language. It wasn't the end all be all, but we've moved on to individualized medicine. We know we need to account for global alignment. Many of these cases are not cervical specific deformities in and of themselves, and failure to recognize this is a guarantee to fail. And in order to do this, you really need to identify the relationships between the C2 and the T1 slopes and the thresholds that have been published. We've also learned, our own Hanjo is going to talk about this. I'll just touch upon it. We know not all cervical deformities are the same. They have different patient presentations. They require different alignments. Case in point, this is a patient of mine who excised a recurrent intradural lipoma, as well as performed a 3-column osteotomy on a rigid post-laminectomy kyphosis and required a long fusion for a cervicothoracic deformity, whereas this patient was a focal deformity with no thoracic or global malalignment that did well with a similar 3-column release, but a short fusion. We know that the shape and proportion also matters. I'm not going to go into details here, but to minimize mechanical complications as well as to minimize dysphagia from hyperlordosis in the upper cervical spine, as you can see there. Flexibility matters. We published this classification on releases. So certain patients can get away with uncovertebral releases and soft tissue releases, such as this patient, whereas others need 3-column releases, such as this patient of mine, in order to achieve an optimal realignment. And finally, it's not just about the radiographs. We know that this is a patient population that's at risk. Using traditional metrics, they're ubiquitously frail. And this results in increased complication rates, increased distal junctional failure rates, increased mortality. But we didn't have the tools really to assess it because everyone was considered frail. So we developed this modified cervical deformity frailty index really to cipher out the most severe frail patients that needed to be treated prior to surgery. This allowed us to modify our targets, and then we then needed to adjust the amount of risk we proposed to our patients with the invasiveness of our surgeries. So this invasiveness index really helped us titrate based on the frailty. So bringing it all together, we have advanced surgical planning techniques, and now we have advanced optimization techniques that are developing, maybe not as advanced as our understanding of realignment. And hopefully these evidence-based pathways can improve outcomes in spine surgery. So in conclusion, successful realignment in adult cervical deformity requires perspective, preparation, individualization, and future goals include quantifying the optimization process and refining existing protocols. Thank you again for this opportunity.
Peter, great talk, packed full of information that we can all take home and change practice and change the care of our patients. A couple of questions from our audience and myself. A successful ERAS protocol is really dependent on the partnership with anesthesia and pain and other folks. Can you talk a little bit about your process for building a team around you that can develop successful implementation of ERAS?
Yeah, I think that's very important. I think if you have to start with one, and there's certainly multidisciplinary teams that need to be established, but if you have to start with one, I would say, come up with a partner on the anesthesia end. I was fortunate. I've been 2 years at my current institution, and there was an anesthesiologist that started from Tampa, Dr. Bosma, who started around the same time, who really, that was her focus. And obviously that was a big focus of mine, back in New York. So we've kind of become good friends, and we're working on developing a lot of these. Also, we started a bone optimization clinic, which was through our own department and division, which is separate to minimize delays from seeing traditional, endocrine pathways. Although we certainly work with them as well for complicated patients. So, I totally agree. I think it really takes specialties beyond our knowledge sets, and to implement them, you really need partners in this, and that's a big part of this process.
Kind of dovetails into my second question, which is really focused around the osteoporosis and recognition and management, particularly who does that at Duke. For us, we had this intense bottleneck with rheumatology, and we actually recently had our rheumatology nurse practitioner go out on maternity leave, and it's like shut down our our deformity practice, and it's kind of left us with questions about how best to manage it. I heard you said you have them in your own department. Is that something that has been successful, and what tips would you give for those of us?
It's a challenge. I think it's really a developing issue at many institutions, that historically this has not been a focus. To be honest, in New York, I had a lot of support in my office, and we would get a lot of the prior authorization processes approved on our own, because of exactly what you said. It was a very long delay to see rheumatology. Certainly we'd use them in complicated cases. I think, it was something that really didn't exist to a large extent, when we started, and we were fortunate. Trauma, actually, the orthopedic trauma team had developed a bone metabolic clinic for follow-up, and we followed that model. And one of our spine surgeons that's been in practice really for probably the longest time of any of us at our institution, was gracious enough to start the metabolic bone clinic as kind of when he stopped operating, Dr. Richardson. So I think that's we've had that benefit, but we meet with endocrinology and others, because there's a lot of patients that have whether it's renal osteodystrophy or other more complicated cases, that's not as simple as ordering an anabolic. The other component, I would say, is the authorization process is historically very difficult, and we know that traditional metrics miss osteoporosis 30-40% of the time. So, even though we can sit there and measure the Hounsfield units at T2, and diagnose our patients, it's a difference between us diagnosing them and the DEXA being normal and trying to get an anabolic approved prior to surgery. It has gotten a little bit better, but even when it gets approved, there's a cost component. A lot of the companies do have patient-assisted hotlines, which sometimes can be helpful. But I really think it's worth the wait. Where we run into it is progressive myelopathy or significant neurologic issues, and then we don't have the luxury of waiting as long, and that's always a difficult decision. How long do we wait? Sometimes what I'll do is I'll do an anterior procedure, try to get the anabolic started, and do a more extensive posterior procedure to kind of delay.
It's great. Yeah, it's somewhat of a data-free zone, and I think we all have our own sort of algorithms, and it might be an opportunity for us to kind of get together and maybe with a few other centers and look at outcomes, especially with the questions around duration and the different efficacy between the three anabolic treatments available.
Yeah, that'd be great.
Peter, thanks for a great talk. Really appreciate your time and expertise in this area. Our next speaker is Dr. Hanjo Kim. Dr. Kim is the director of the Spine Fellowship at the Hospital for Special Surgery and a professor of orthopedic surgery at Weill Cornell Medical College. He's a globally recognized leader in spinal deformity surgery with extensive contributions to cervical deformity classification, surgical strategy, and outcomes. His work has helped shape modern approaches to complex deformity correction. And tonight, he'll be presenting on principles of level selection for surgical treatment of cervical deformity. Dr. Kim, very thankful for sharing your expertise and insight with us this evening. Thanks for your time.
Thanks, Dr. Stevens. So also thank you to the CSRS for this opportunity and for giving me a sort of platform on a Wednesday evening to talk about cervical deformity and level selection. So I think I want to start with a case. So this is something that I used to get questions about often. I'm sure all of us do in our clinics, but this is a 68-year-old gentleman who has a clear cervical deformity with a dropped head syndrome, mild history of a central spinal cord compression, as well as some signs of early myelopathy. He has some difficulty with horizontal gaze and worsening posture and balance, and progressive exercise intolerance as an avid marathon runner. The question is, what do you do with these patients? What segments do you fuse them to? It's something that we discuss all the time in our indications conference, and it always seems to be one of those situations where you ask 10 different surgeons and you'll get 15 different opinions. If we're going to think about level selection for cervical spine deformity patients, I think we have to go back to the way that we think about level selection, even in thoracolumbar cases. When we looked at a subset of patients with cervical deformity and look at T1 slope to cervical lordosis mismatch patients, and we looked at the subset of patients who had extension x-rays as part of the decision-making for their surgical level selection, what we found is that the utility of the extension x-rays were critical in devising a surgical plan, not just level selection, but also in regards to the invasiveness of surgery, such as a type of osteotomy. So this is sort of akin to supine x-rays, for example, in patients with scoliosis. And as we know, in scoliosis, one of the classification schemes that has been extremely useful for the treatment of AIS, for example, has been the utility of sort of extension, or in this case, bending x-ray, so dynamic radiographs, in order to help us define level selection. So according to, for example, the Lenke classification for adolescent idiopathic scoliosis, what we see is that once you classify the type of curve based on the standing x-rays and the side bending x-rays, as well as the lateral x-ray, you could then decide on the level selection. Now, it won't work 100% of the time. I don't think any of these classification systems do, because we always have exceptions. Especially in adults, it's a little bit different because it's not just level selection. You have to look at pre-existing degeneration or areas of stenosis that would need to be addressed concomitantly with a deformity operation. But nonetheless, it gives us a framework for us to think about how we could approach these patients. So this is sort of what gave us the motivation to study different cervical deformity morphotypes in relation to sorry, I'm trying to move the screen. In relation to their everybody see my screen? I hope so.
Yeah, we got you.
Okay, great. To look at different morphotypes in cervical deformity patients to decide whether or not they would be candidates for different types of surgery. So the reason why this is important is because we actually started to integrate the extension x-rays on the cervical spine images to help us decide on that level selection. When we looked at this over a clustering sort of methodology, what we found is that there were three main types of cervical deformity. One is flat neck. Type 2 was focal deformity within the cervical spine, and cervical thoracic deformities, which were group 3. And basically, the characterizing feature for each group, I'll go through here. So group 1 patients were patients who had very on the low side cervical lordosis under the setting of a relatively normal T1 slope. And because they couldn't generate the cervical lordosis, they also ended up with the elevated cervical SVA, resulting in their cervical deformity. So a lot of the patients in this group also had prior cervical fusions and were fused with sort of a flat neck sort of position by the time they needed their revision operation. So basically, these patients, in summary, are patients who have large T1 slope to cervical lordosis mismatch, mostly due to insufficient cervical lordosis, not because of a very high T1 slope like our type 3 counterparts, which I'll go into. And because of that, most of these patients will have cervical thoracic drivers for deformity. These patients are more likely to be those who have somewhat flexible deformities without the need for large operations and three-column osteotomies. Most of them, as far as level selection is concerned, could get away, quote unquote, get away with a level selection at the lowest instrumented vertebra anywhere in the upper thoracic spine from T1, 2, 3, and even T4 at times. Sometimes, depending on the type of deformity, obviously, these patients could also undergo combined anterior-posterior surgery or all posterior approaches. Type 2 are patients who have focal deformities within the cervical spine, and sort of the distinguishing feature for these patients is that their T1 slope is relatively low and very normal. And their cervical kyphosis within the cervical levels is what defines this group, sort of how you could see that X-ray on the right side of the PowerPoint presentation. These patients have basically cervical kyphosis that extends over 2 or 3 adjacent segments. Their overall cervical SVA, however, is maintained and less than 4 centimeters. Their T1 slope is small, and most of them have purely cervical drivers for deformity. So when you decide on level selections for these are patients that you could usually stay within the cervical spine for. Now, if you do a 4-level ACDF and you like to back those up, of course, that would be an anterior-posterior type of surgery. But if you could develop the alignment that's necessary and also take care of any concomitant stenosis by staying with an all anterior approach for these cases, that's of course very possible as well. Next is the group 3 patients, and these patients are patients who have cervical lordosis, which is relatively high compared to our group 1 counterpoints, but their T1 slope is supraphysiologic. What I mean by that is it's extremely high, and what we see is that because of the high T1 slope, about 54 degrees, they cannot generate the cervical lordosis that's necessary to maintain a normal cervical sagittal balance. So they start to decompensate because of that large T1 slope, and the cervical lordosis can never really catch up. These patients have thoracic or thoracolumbar deformity drivers, and because of that, when it comes to level selection for these patients, they're more likely going to need 3-column osteotomies within the thoracic spine to normalize that T1 slope, especially if they have stiff deformities. And a lot of these patients, some tend to be those patients who have upper thoracic to pelvis type fusions with failures, junctional failures that need revision surgery. So in summary, this is sort of an alignment based dynamic radiographs based surgical selection level for cervical deformity patients. And I think, whether or not you agree with the classification system or not, it just points to the fact that the extension X-rays or dynamic radiographs in general are really important for us in trying to decide fusion level selection for these patients. When we looked at the subset of patients and looked at our surgical strategy, this is sort of after we came up with the cluster. What we found is that indeed the surgical strategies were different between all groups, statistically significant difference in regards to the level selection, in addition to the rate of use of 3-column osteotomies. And the good thing about this classification system, I think, is that compared to previous classification systems, the intra and inter-rater reliability is actually very good, about high 80 percentile or 90 percentile, even amongst trainees as well as attendings. No discussion about level selection is complete without a discussion about osteotomy selection and location to place the osteotomy. And just a brief review of osteotomies and what we could achieve with that. 10 degrees for a given posterior column osteotomy, 35 degrees for a PSO in the cervical spine, anterior osteotomies, about 17 degrees alone. And then when you combine that with the posterior column osteotomy for a front BRAC approach, you could approach almost 30 degrees of correction. Now, the reason why I bring that up is because the anterior osteotomy, especially if we combine it with a anterior posterior approach, it seems like the correction that we could achieve is almost very close to a pedicle subtraction osteotomy without some of the neurologic dangers that are associated with PSOs, longer operative times, and blood loss that we see. And it also allows us to address deformities, for example, that are up at C5 and C6, where the vertebral artery is present and going to affect our ability to approach that pedicle with much less stress. When we looked at our data for this, what we found is that when you did the anterior osteotomy and a posterior combined osteotomy, you could see here up to 32 degrees of correction, the combined approach. So you have to ask yourself, is it really worth it to do a PSO when in our series, what we saw is a given PSO had about 700 cc's of blood loss compared to an anterior posterior for similar correction, angular as well as translational correction that resulted in just half that much blood loss. Maybe slightly longer operative time because of the flip that's necessary and the repositioning, but nonetheless, a significant lower physiologic burden to the patient. Osteotomy location is really important, and this is something that I've learned through my own experience, but also obviously this is Chris Ames's series, but I would say that I have gone now to moving my 3-column osteotomies to the upper thoracic spine. I think early on in my career, I was doing C7 PSOs much more regularly, but I started to recognize that the incidence of C8 palsies for these patients or neuropraxias without any radiographic abnormality was starting to become a little too prevalent in my hands. So we have moved those osteotomies further distally. Now most of my PSOs will be around the T2 or T3 region, and knock on wood, I have not seen similar rates of lower trunk brachial plexus issues with that. Here are a couple of cases, a 73-year-old with rheumatoid arthritis. I think this is a patient that you could classify looking at the extension radiographs that originally with 25 degrees of kyphosis and ends up with still 15 degrees of persistent kyphosis and extension. This is a type 1 group 1 flat neck deformity patient because their T1 slope is relatively normal and their cervical lordosis cannot be generated sufficiently enough for them to have a normal cervical SVA. Now, this is a patient that traditionally I probably would have done a C7 PSO for, but because of the literature and the way that we saw the data on combined anterior and posterior approaches for this specific type of deformity, I actually decided to approach this patient with an anterior osteotomy at the C5-6 segment, and then a single SPO at the 5-6 segment as well, and then taking the patient down just to the T2 segment. And you can see here a good clinical result in regards to his clinical deformity as well as radiographically. Here's a patient that's sort of a clear-cut example of a type 2 deformity, focal kyphosis of 24 degrees, a normal T1 slope, cervical SVA, which is maintained, and on extension radiographs with persistent cervical kyphosis. Obviously, multi-level cervical stenosis essentially, as well as in the foramen, sort of a myeloradiculopathy type of picture. And according to the classification scheme, this patient just underwent a 4-level ACDF. This is a construct that I do more recently with titanium cages at the most distal extent. You can see here this is already a 6-month radiograph, but fusion is already achieved and good consolidating fusion across all 4 segments. And next I'm going to talk about type 3, and this is sort of a 63-year-old where you could see how a type 3 deformity really looks. You can see here a very high T1 slope that's sort of fixed and rigid. Patient had multiple prior surgery, I think 8 prior surgeries that extended not only from a prior scoliosis surgery, but then that one that was then complicated by a junctional failure from trauma, an extension up into the cervical spine that was then complicated by a DJK that happened through the fusion mass of her prior CDI instrumentation. And here, this is a case where I decided to do a T3 PSO, elevated T1 slope here, and you can see that based on the deformity, this is a type 3 elevated T1 slope that is supraphysiologic and unable to generate the cervical lordosis necessary to maintain upright posture and horizontal gaze. So this patient underwent, again, a T3 PSO with adequate alignment and correction and did well after surgery. Now, the case that I started with is this case. So a 68-year-old patient who is an avid marathon runner developed progressive cervical thoracic kyphosis, inability to hold his head up, and that was not really correctable on supine images. Here is images from 2024. And you can see her close up PI of 60. And PI of 60, I would expect a T1 slope to be closer to around 30 or 20 to 25 degrees. Here, you can see his T1 slope is actually not so bad. And I think this is a case where if I didn't have the classification system in the past, I probably would have said I'm doing a C2 to T10 type of operation. But if I applied the classification system and I look at the dynamic radiographs, what I realize is that actually on the extension radiographs, the deformity is not as bad as we originally think it is based on the standing images. And then the supine radiographs also sort of confirm that thought and hypothesis in the way that we think about these patients. Now, this is some areas of cervical stenosis as well, and obviously this has to be addressed in the operation, and that was addressed in the operation in our approach, and this is just a CT scan demonstrating the patient's alignment. So basically, this is the case I started with, and this is the case that I'll end with. According to the classification system, actually, this patient is a group 1 flat neck patient. And that means that if I trust the classification system, I could actually do a fusion that just stops in the upper thoracic spine. And that's exactly what we did. We did a C2 to T4 with multiple level SPOs, a few laminotomies at the areas of stenosis and the areas that we saw on the MRI. And actually, the patient did well postoperatively without distal junctional kyphosis or failure, a nice harmonious kyphosis there you could see in the thoracic spine, and actually just completed his first half marathon about a year and a half out from surgery. So this is sort of my algorithm. For those of you that are joining the webinar and want to take a screenshot, this is sort of the algorithm that I use for treating our cervical deformity patients when it comes to level selection. Thank you very much.
Great cases and talk, Hanjo. Incredible application of cases to your classification system. A couple questions have come up in the chat regarding positioning in particular. So can you talk a little bit about how some positioning tips? I know there's some great technique articles out there for those of you who haven't read it about the anterior osteotomy. I believe that's a JBJS paper. You can correct me if I'm wrong, but lots of really good technique articles out of there. But can you give the audience some quick pearls about positioning these patients in these surgeries?
Yeah, so I usually position these patients with Gardner-Wells tongs in bivector traction. I think, you could use a halo as well. I prefer to use the Gardner-Wells when possible because it also avoids the scarring in the anterior forehead. I think patients sometimes when they have that, they're not as happy about it. So the Gardner-Wells tongs, I think, are very helpful with bivector traction. You could stay scrubbed in the entire case, and you could start the case on the flexion rope with the bed in as much Trendelenburg reverse Trendelenburg as possible to keep the head sort of higher. And then after the approach is done, your instrumentation's in, and you start the osteotomy where you could utilize the extension rope to put the head up in the extended position, which is sort of where you want to achieve your correction. And you could still do that while you're entirely scrubbed. The anesthesiologist just has to change the rope while you hold the Gardner-Wells up while they're changing the weights from the extension, from the flexion to the extension rope.
Great. Then one more question from the crowd. Why a titanium cage only at the caudal level?
Yeah, so I've been using that approach. That case was probably from about 4 years ago, but I've been doing that. I was doing that approach in the past because what I found is that when I was using allograft for all 4 levels for like a 4-level ACDF, the distal one would be higher likelihood to have the graft sort of subside, but also resorb. And I wanted to avoid that. So what I would do is for these cases, take all the bone dust that I can and put it in a titanium cage at the distal level and bone dust from, prepping all the other 4 levels. And then have that with the most autograft concentration as possible, and then place the titanium cage in that segment to prevent that resorption and to give that level a little bit more time to heal. Now, since that time, I have gone to this is a sort of an off-market application, but utilizing BMP in the anterior cervical spine. And since then, I've gone away from using the titanium cage at the distal most level. I just use an allograft ring because it's the cheapest, because the BMP is expensive. So I'm trying to offset cost and put basically a quarter sponge in each allograft ring cage. The reason why I like the ring cages is because it doesn't really allow for seepage of any of the BMP. Some of these titanium cages, they have a hole in the middle, but they also have holes all the way around the cage. And I really want to try to keep the BMP contained.
Yeah, I think something to definitely talk about on that subject is the dose of BMP. Can you just tell people? And of course, this is off label.
Of course, yeah, this is off label, but basically what I would do is for my 3 and 4 level ACDFs, I will take a extra small kit, which is 1 sponge. I take the sponge and my scrub tech will cut it into quarters. So if I do a 3 level ACDF, unfortunately, 1/4 will go to waste. But if I do a 4 level ACDF, all 4 pieces from that single sponge will go into each level. And we're actually going to publish on our series probably next year because we want to have a good 2-year follow-up on it. But I could tell you the fusion levels are very, very promising. And we did have, however, less than a handful. I would think about 2 or 3 cases of seromas that have formed in the anterior cervical spine, usually around post-op day 5 to 8. The patients will call, they'll be fine before that. And then they'll say, I'm starting to get a little swelling in my neck. I don't know what it is. And the first time that happened, I thought it was a hematoma. So I brought them in, I got images. And then what we realized is that it was actually just a seroma. And actually went in to explore one of the patients, and it was just clear, sort of clear liquid, like no evidence of a hematoma, but a fluid collection from the BMP. So since then, we've gone to basically utilizing a little bit of a different technique in regards to steroid usage and trying to block off and seal off that BMP as much as possible with things like Test-Seal or Duraseal in the anterior cervical spine during the surgery.
Awesome. Great tips and tricks. Thanks a lot, Hanjo. Our final speaker this evening is Dr. John Rhee. Dr. Rhee is a professor of orthopedic surgery at Emory University and former president of the Cervical Spine Research Society. He's widely respected for his work in cervical spine surgery, including degenerative conditions, deformity, and surgical technique. He's been incredibly involved with our organization, serving in multiple leadership roles, and has served as an incredible mentor for so many surgeons that have trained with him and under him. John, thanks for joining us and sharing your expertise on concepts and techniques to prevent iatrogenic cervical spine deformity.
I want to congratulate Byron for putting together an awesome webinar. And I get to be the caboose tonight, and probably the only thing between you and a good night's sleep. So hopefully we'll make it worth your time. I'm going to talk about preventing iatrogenic cervical deformity. And in medicine, we have this adage, right? An ounce of prevention is worth a pound of cure. And in the cervical spine, I think that is really, really appropriate, because the truth of the matter is that every cervical spine patient is basically one ill-conceived or poorly executed operation away from developing a major cervical spine deformity. And historically, the main culprit has been multi-level laminectomy, which, as you know, can cause this sort of post-laminectomy kyphosis. This is a patient who underwent an occiput to C2 laminectomy, presumably for cervicogenic headaches. It was not a Chiari malformation. Unfortunately, the patient didn't get better, so the surgeon then decided to do additional laminectomies from C3 to C7, and predictably, you could see what happened at 8 years with a severe cervical deformity. But the truth of the matter is that even operations that were designed to mitigate against post-laminectomy kyphosis, like laminoplasty, can also be associated with loss of lordosis and, in some cases, frank kyphosis. So this is a patient of mine who's a medical doctor. He had myelopathy. I performed a laminoplasty on him, and he did very well symptomatically. His myelopathy basically went away, and he had no pain. But the x-rays just don't look very good, and I kind of cringe every time I see him in the office with these x-rays. This paper by Professor Sook about 20 years ago now showed that on average, laminoplasty patients lose about 5 degrees of lordosis after open door surgery. And in this series, about 11% of their patients developed a new onset kyphosis that had not been present preoperatively. And even anterior surgery, which we normally think of as being good in terms of sagittal alignment, can lead to iatrogenic deformity as well. So this is a 76-year-old man who underwent a laminoplasty at an outside hospital. And I don't have his x-rays at the time, but he assures me that after the laminoplasty, he was doing fine and he had no alignment-related issues. But then the surgeon went in and did an ACDF, and that's when all of his alignment problems started. And if we're critical and look at these x-rays, you can see that they took a very large cage and kind of stuffed it into the disc space without appropriate height restoration. And the plate fixation and the screws obviously leave something to be desired. So that the patient ended up fusing, but they fused in 26 degrees of segmental kyphosis, which combined with the weakened extensor muscles from the previous laminoplasty led to this sort of global malalignment problem that then required a major anterior-posterior reconstruction. So given all of that, are there some principles that we can utilize to prevent iatrogenic deformities from occurring after degenerative cervical spine operations? Let's start by discussing strategies for laminoplasty. In my opinion, preventing post-laminoplasty deformity or loss of alignment really comes down to two factors. The first and probably most critical is proper patient selection. And in my practice, I avoid laminoplasty in patients who have any degree of kyphosis, particularly if they have a high cervical SVA. And here's why. Because if you are lordotic and have a low cervical SVA, that means that your head is well balanced over your spine. And so the weight-bearing axis of the head actually helps to maintain your sagittal alignment. This has been referred to as an economical or energy efficient position. So think about a modified bowling pin that has a ball resting on top of it. The weight-bearing axis of that ball actually helps to maintain the alignment. And in the cervical spine, that means that the extensor muscles don't have to work very hard to keep the head where it is. In contrast, if you have kyphosis, in particular with an associated positive cervical SVA, now the center of gravity of the head is much more anterior, and the weight-bearing axis of the head actually exerts a kyphogenic moment on the cervical spine. So to go back to that analogy, the pin is now placed at an angle, and there's no way that the bowling ball is going to sit on top of that pin. That means in the cervical spine that the extensor muscles have to work overtime to try to maintain the alignment, and over time they can stretch, fatigue, and generate kyphosis. So as much as I love laminoplasty, and I think it's a great operation, it's not for everybody. And I think you have to pick your laminoplasty patients very carefully. So here's a case of a patient who has only 5 degrees of kyphosis. And in the literature, this would be totally acceptable for good neurologic outcomes. But if you look closely, you can see that his CSVA is moderately positive, about 4 centimeters. So in my opinion, if you combine this kyphosis with a positive cervical SVA, this patient is a setup for losing more lordosis after laminoplasty, and it would not be my first choice operation. Now, that doesn't mean that the alignment has to be perfect in order to do a laminoplasty. This is an older man with myelopathy. He has a horrible looking spine. In the upper cervical spine, he's actually kyphotic. But if you look closely, you can notice that he has lordosis where it counts, which is in the area of the spinal cord compression. So in somebody like this, we could do a focal laminoplasty at the levels of cord compression, relieve his myelopathy, and leave the alignment completely unchanged. Another option with laminoplasty is to do associated focal ACDFs so that you can get the benefit of neurologic decompression over multiple levels, but not have to fuse every single one of those levels. So here's a 34-year-old man I did recently. He's young, you want to preserve his motion. He has severe progressive myelopathy with these large focal disc herniations, particularly at C3-4 and C4-5, associated with congenital stenosis. If you look at his neutral lateral x-ray, he only has about 2 degrees of lordosis. And if you superimpose the disc herniations on that x-ray, you see that the K-line is therefore negative. And that means that a posterior decompression is unlikely to satisfactorily decompress the cord completely. So what we did is we did an ACDF at that segment to get rid of the focal protrusion, but also to subtly improve the alignment so that now the K-line is positive and the laminoplasty can do a better job at achieving full spinal cord decompression. The second strategy in preventing post-laminoplasty deformities is a careful management and protection of the cervical extensor muscles. And I often tell the residents and fellows that I work with that laminoplasty is as much a muscle or soft tissue operation as it is a bone operation. And to maintain sagittal alignment, I think it's very helpful to do a C3 laminectomy at the proximal end of the construct rather than a laminoplasty. And in this study that we published several years ago now, we showed that a C3 laminectomy leads to significantly less loss of lordosis than a C3 laminoplasty, on average about 5 degrees less. And the reason why is because if you do a C3 laminectomy, you don't have to detach any of the C2 muscle insertions to do the laminectomy. You can kind of work underneath all of that and leave the insertions completely intact. On the other hand, if you do a C3 laminoplasty, because of the shingling effect of C2 on C3, there's some amount of detachment of the C2 insertions that's basically unavoidable to be able to uncover C2 off of C3 and then be able to open up the laminoplasty. So in my experience, if you do a C3 laminectomy at the top of the construct, in general, lordotic patients like this stay lordotic, and neutral patients like this stay neutral. What about laminectomy and fusion? How do we prevent deformities from occurring after those operations? Well, one of the important factors to consider is proper positioning. And of course, you need to consider two vectors. Lordosis is obvious. So whenever we position patients with my trainees, I notice that the residents and fellows are keenly attuned to increasing lordosis during positioning. But what they're often not attuned to is the sagittal balance. And while lordosis is more of a rotational vector, the sagittal balance is translational. And that is absolutely critical, probably even more important than lordosis if you're doing a cervical thoracic fusion and locking the patient into that alignment. The second thing to consider when performing posterior laminectomy and fusion is to optimize the posterior fixation. And we all know that lateral mass screws are generally weak. And one way to mitigate against that is to use subaxial cervical pedicle screws, which is something that I've been doing more and more frequently. So this is an osteoporotic patient. It's a patient of mine. On postoperative day 2, everything looked fine, and I thought I'd done a good job. We did bicortical lateral mass screws, etc. But you can see by 6 weeks post-op, she had pulled out her proximal screws. And on the CT scan, you can see that the lateral mass tracts at C3 and C4 are completely blown out as the screws pulled away. So in this case, we needed to do a C2 to T2 revision fusion, but now doing an all pedicle screw construct that would be much stronger and provide the alignment and the fixation that was needed to heal this patient's cervical spine and myelopathy. Another way to optimize fixation is what's called the pedicle inlet or the pillar acronym screws. Now, I have to give you a little caveat here. I am a consultant for Medtronic, and so we are developing this technique, and so I would ask you to keep that in mind as you evaluate what I say. But the pillar screw is basically a shorter, safer version of a pedicle screw. The trajectory is about the same as the pedicle screw, but it engages the strong bone of the pedicle inlet, but it doesn't go all the way through the pedicle, so you can avoid the dangers of traversing the pedicle, namely the vertebral artery on one side and the nerve root on the other. And biomechanical studies have shown that these pillar screws are about 51% better in terms of pullout strength versus lateral mass screws. Obviously, they're not going to be quite as good as pedicle screws, but they're a lot better than your traditional lateral mass screws. So here's a 21-year-old college student who presented with a weakness in the left arm and left leg. You can see that there is significant kyphosis and even a cervical scoliosis. And on her MRI, she has severe cord compression with it being draped over from C3 to C6 and the cord being really, really atrophied. So obviously, in order to treat this patient, you need to decompress the spine, but you also need to realign it because that's part of treating the myelopathy is to get the cord off of the ventral aspect of the vertebral bodies. And when you look at fixation, you need strong fixation, but this patient has very small abnormal lateral masses. The vast majority of them are less than 10 millimeters in length. If you then look to the pedicles, well, at least on the right side, there are pedicles. They're fairly small, but they're present. But on the left side, many of the pedicles are just not available for any sort of fixation at all. So what we did in this patient is we used pedicle screws where the anatomy allowed. And in the areas where there essentially was no pedicle, we used the pedicle inlet technique. And by doing this, we were able to achieve very strong fixation so that we can use it for corrective maneuvers and achieve about 50 degrees of correction over the operative levels. And the goal here was to fuse and decompress and stabilize the spine, but do so with the fewest number of segments being fused in this 21-year-old college student. And then finally, what about preventing iatrogenic deformities after anterior surgery? Well, one of the principles that I think is important is to fill the disc space with as large a graft as possible for better maintenance of alignment and deformity correction. And in that regard, my current graft preference is to use these large footprint lordotic cages because they better fill the disc space, which means better load sharing and generally less settling over time. And Hardeep Singh, who was one of our clinical fellows several years ago, published this paper with me showing that these large footprint cages better preserve lordosis that was achieved at the time of surgery. So with the cages per level, we usually get about 6 degrees of lordosis. And at 1 year, the vast majority of that lordosis was maintained. With allograft, however, you got similar amounts of initial correction, 5.6 degrees, but by 1 year, about half of that correction had been lost, probably due to bone resorption during the healing process, as well as settling due to the unfavorable biomechanics. So this is a patient with a mild deformity, 12 degrees of kyphosis, that we treated with this technique. And at 1 year post-op, all of the lordosis that we achieved at the time of surgery was maintained. I would also caution you during anterior surgery to be careful with standalone cages, especially small ones like this that use shims for fixation. If they heal, they often heal in this sort of segmental kyphosis. Even with the screw cage constructs like this, again, if they're small, they can heal in this sort of segmental kyphosis. And contrast that to the lower levels that we performed for adjacent segment problems using larger cages, larger screws, and a plate, and that leads to better fixation and overall better maintenance of alignment. Now, I don't think these standalone cages are bad necessarily, and I do use them, but typically as part of anterior-posterior constructs. So this is a patient who had 2 previous ACDFs. He also had a non-union and adjacent segment disease. And so in this case, I did a 2-level standalone anterior to avoid any kind of need for plate removal. It's a lower profile instrumentation, and we were doing supplemental posterior fixation anyway, so you don't need something super rigid up in the front. So in conclusion, I really do think that an ounce of prevention is worth a pound of cure, particularly in the cervical spine. And I would recommend that you keep these considerations in mind to prevent iatrogenic deformities from occurring with your degenerative operations. If you are interested in cervical deformity talks, or for that matter, a talk on any aspect of cervical spine, I would refer you to our YouTube channel and the CSRS video archive, where there are talks from the CSRS membership, including myself, Hanjo, Peter, and others. And I think you will find this to be a very valuable resource. So thank you for your attention, and I welcome any questions that you might have.
Thanks, Dr. Rhee. As always, a masterclass in PowerPoint presentations and presentations in general. I was wondering if you could provide the audience with some pearls on your dissection techniques for laminoplasty in particular, in terms of how far out you aim to expose, on the lateral mass, and pearls for not overexposing at C2, et cetera.
Yeah, I think the vast majority of the time you can do a C3 laminectomy without detaching any muscle fibers off of C2 at all. And so that's fairly easy to do. And as I mentioned, once you expose C3, even with all the C2 muscle insertions, you can do a laminectomy of C3 working underneath that and not have to detach it at all. So that's really important. Out laterally, I go just past the lateral mass laminar junction. Obviously, on the plated side, you have to go a little bit further because you have to put the plate on, but on the hinge side, you just go just past the lateral mass laminar junction. And when you work with trainees, everyone's instinct is to keep going laterally. So you got to fight that instinct when you're doing laminoplasty. The other thing that I didn't get a chance to mention is that the muscle closure is really, really important for all posterior cervical operations, but in particular, laminoplasty, because you need those muscles to function. So what I do is after the surgery is done, I take Vicryl sutures and I gently oppose or reapproximate all the muscles together. And then I approximate the fascia to the muscle so that hopefully you get one, functional layer. And also try to do the laminoplasty as reasonably quick as possible so you're not causing ischemia to the muscles during the surgery.
Great. All great tips. Maybe one last question from the audience. It says, what are your thoughts on segmental plating with regards to alignment in 3 or 4 level constructs? Is there any concern for iatrogenic deformity similar to standalone constructs?
So I have to say that's a great question. I don't have any experience with 3 or 4 levels. What do they call it? Segmental plating. That's basically, for those of you who don't know, doing a single plate at every single level. I use plates as a means of achieving additional anterior correction. And so for me, having a 3-level plate really helps in getting a few additional degrees of lordosis. Sometimes you can get significantly increased amounts of lordosis through a combination of releases, grafting with appropriate size cages, positioning, repositioning the patient after you've released the disc, and then using plates to basically bring the spine up to the plate and generate additional lordosis. So that's my preferred technique.
Great. Any tips on that last piece of essentially bringing the spine to the plate in the middle levels of the fusion?
Yeah, so overbend the plate. The plates always come with some lordosis, but it's never as much as you want. So overbend the plate. You do have to be careful about not overdoing it to the point where the locking mechanism won't function. But bend the plate as much as you can and use long screws.
Great. Well, with that, I think we're out of time. I'd like to again thank all 3 of our speakers tonight. It's been a really incredible series of talks with incredible wisdom and pearls and tips and tricks. So thank you all for your time. And I'd also like to thank our audience for their attention and participation in tonight's event. So thanks, everybody.